So the last part is focusing on some clinical cases to try and embed what we've heard and learnt in part 1 and 2. My case that I will talk through really is of a lady that I met about 7 years ago. She's a 70-year-old Caucasian female who presented to our dermatology colleagues with a further review. She'd had a maculopapular rash for 4 years. She was diagnosed with skin urticaria pigmentosa. You can see a typical image of the rash on the right there. And she didn't have any palpable organomegaly when she was seen, but the additional symptoms she developed were intermittent diarrhea, low back pain, occasional PR bleeding, and weight loss. Her initial investigations at the time she was seen are summarised here, and she was noted to have a reasonably normal full blood count. She had a tryptase level of 80 and a raised alkaline phosphatase of 241. So we are polling at this point. At this point, what would your diagnosis be? Would it be indolent SM, inflammatory bowel disease, mast cell in the skin, or aggressive SM? If you would vote now, you have 20 seconds. Thank you. So thank you very much. So 60% of the audience feel the diagnosis would be indolent SM, 20% mast cell in the skin, and 20% aggressive SM. And as this is a talk on SM, no one's decided to go for inflammatory bowel disease. Moving on, at this point, the diagnosis in terms of classification would be mast cell in the skin, because you haven't confirmed the diagnosis of SM by bone marrow or a biopsy, a histological diagnosis. She was treated with sodium chromoglycate, a mast cell stabilizer, fexofenadine, in order to manage her symptoms, and responded reasonably well. She was referred to the GI team to exclude IBD, because not everything is mast cell related, or is it to confirm she had mastocytosis? And she was referred to our team as a bone marrow biopsy was recommended and required. And this is her diagnostic workup from the GI team. She had a colonoscopy, and as you can see from the images here, the HNE, there were scattered mast cells that were positive for CD25 and CD117, confirming clonal mast cells were present. And as a result of this biopsy, her diagnosis was made of indolent systemic mastocytosis. Clinically, she was well. She had managed to have stabilization of her symptoms with the anti-mediator therapy. She had mild splenomegaly noted on the ultrasound, and she had a DEXA scan which showed she had osteopenia. 6 months later, she had an acute admission. She had increasing splenomegaly, she had ascites, and was thought to have portal hypertension with esophageal varices. The management plan as an inpatient was paracentesis in order to make sure that she was better. We commenced prednisolone at high dose, 60 milligrams once a day, and continued on her antihistamines while we carried out further investigations. Her investigations are highlighted here at that point. Her hemoglobin was reasonably well preserved, white cell count as well. And we noticed that her monocyte count has increased from the baseline that we saw of 1.5 to 2.4. Her tryptase was slightly raised, and her alkaline phosphatase was further raised. Her albumin was within acceptable limits. She had mild splenomegaly still, but she had patent intrahepatic and intraportal vessels. She had markositis on the CT scan, and we continued with the treatment as was, but we carried out a bone marrow biopsy. Here is her bone marrow biopsy from 2016. I'll walk you through the panels. So she had a hypercellular bone marrow, looking at the top panel and moving to the right, with expanded granular paresis and mast cell aggregates that showed that they're usually quite pale and can be associated with some fibrosis. In the panel below, the mast cell aggregates are highlighted with the CD117 marker, but the CD25 was similar, but also picked up an increased monocyte population with the CD14. This was an aspirate in the fact that she had the beautiful spindle-shaped mast cells, and there were less than 20 in that aspirate, so she didn't have mast cell leukemia, but a diagnosis then got changed. At this point, we were diagnosed her with advanced SM, with SM and CMML. What treatment would you start? So if you wouldn't mind polling again, imatinib, midostaurin, cladribine, or azacitidine, and you have 20 seconds. So 100% of the audience went for midostaurin, which is great. You can also use cladribine. That would not have been the wrong answer had you not had midostaurin. Imatinib is the only drug you wouldn't use because she was c-KIT positive, and azacitidine would be an option, but it was really her SM component that needs treating. So moving forward, we did treat her with midostaurin on the compassionate use program. She had a good response. We started off at the dose of 100 milligrams twice a day, and her skin and her GI symptoms were extremely well treated. Her peripheral edema settled, her ascites resolved. She didn't need that drained, particularly her diarrhea improved, and the urticaria pigmentosa faded significantly. But she had a loss of response in October 2017, and that was as a result of a bone marrow biopsy. So we did 6 monthly bone marrows. Her baseline had a 50% disease bulk. It dropped to 10% at 3 months, and then it had gone back up at this point to 50%. At this point, where would you go next? Again, last of the pollings, I think, and we maybe have one more. Imatinib, azacitidine, cladribine, or avapritinib. 20 seconds, please, folks. So avapritinib. My work here is done. I will move forward. So she did actually get avapritinib on the Explorer trial. She was randomized. She started on the 200 milligrams once daily. She had a baseline bone marrow at 60% mast cells. Within 3 months, she had a complete loss of the aggregates. Within 6 months, she was in complete remission. As we've seen from the data, her side effects were periorbital edema and whitening of her hair. She achieved CR on the trial, but unfortunately, we had to withdraw from the trial because she developed loculated abscesses within the gut and had a mild perforation, which led to significant complications with bacterial peritonitis, refractory ascites, and she was getting quite frail. So we pulled out and planned for supportive treatment in 2019. And much to my surprise, in February 19, she came back to clinic. She was much better. Her tryptase was 91. Her blood counts, as they are there, the monocyte count of 1.2. And she wanted to be restarted on treatment as she felt much better. She had 25% mast cells in the trifine. We started avapritinib on a compassionate use program at 100 milligrams alternate days. This is personalized treatment for this patient. It is not how it's been recommended to start. And April this year, she was diagnosed with mild early dementia. This is not related to the avapritinib. And we reduced the dose to every 3 days. Again, very personalized treatment, which is clinically extremely well with controlled counts, a normal ALP, and a tryptase that's rising but not clinically effective. So I guess the learning points are there's a multidisciplinary approach. The diagnostic bone marrow is really important because this lady went from mast cell in the skin to advanced SM. The full tryptase, full blood count parameters, especially looking at the monocytosis and eosinophilia, is really important. And that the tyrosine kinase inhibitors are disease-modifying agents, as we already know. And in this lady, they have shown that they've had an extremely good effect. Thank you. I'll now hand over to Dr. Mannelli to present his case.
Good evening, everybody. The case I am presenting, these are my disclosures, was characterized at the beginning in this 66-year-old male, basically by diarrhea. He underwent a set of assessment initially. The stool cultures and colonoscopy were negative. And the CT scan of the abdomen revealed some lymph node enlargements in mesenteric region. The hemochrome was substantially irrelevant. So how to proceed with the diagnostic workup of this patient? The premise here is that there is no just one right answer. The answer I will give is just how we decided to handle the patient. So please vote. You have 20 seconds. So as in the majority of your votes, we opted for to proceed with the bone marrow biopsy because basically it was, in our view, the more quick way to get to the diagnosis. And actually we revealed an infiltrate of abnormal mast cells equal to 40% of overall cellularity. There was positivity for the typical KIT D860 mutation, and the mast cells were expressed aberrantly CD25 and CD2 at flow cytometry. The serum tryptase that we obtained at this point was just above 350. So we posed the diagnosis of smoldering systemic mastocytosis according to WHO, basically on the absence of C findings and the presence of 2B findings. At the next disease assessment, the patient showed diarrhea, and the initial management of the patient was based on anti-mediator treatment that was started. But actually, there were no ameliorations of any symptom. And at later clinical evaluation, we observed a significant weight loss in the patient together with persistent and invalidating diarrhea. there was also an increased level of alkaline phosphatase at this point. So on the basis of these findings, which diagnosis could be formulated at this disease reassessment? So please vote again. That's fine. So aggressive systemic mastocytosis, basically due to the significant weight loss that was experienced by the patient. So how to proceed now with the evolution into an aggressive systemic mastocytosis? The patient initially was treated with a first-line systemic treatment with steroid at standard dosage, but he actually achieved only mild relief of symptoms. And that was the moment that it was referred to our center. The clinical case met the enrollment criteria for the Pathfinder clinical trial. So we enrolled the patient and started avapritinib at the standard 200 milligrams dose daily in September 2019. This figure actually captures the longitudinal sequence of the spleen volume assessment by MRI. As you can see, the patient experienced a significant and quick reduction in the spleen volume from the 17 centimeter of bipolar diameter at screening up to 14 centimeter after 2 cycles of treatment, and up to basically a normalization of the spleen volume after 6 cycles. In parallel, we observed coherent trends for all disease biomarkers, as you can see in the upper part of the slide, the reduction in the extent of mast cells infiltration of the bone marrow. In the middle, the reduction of the tryptase level, and at the bottom of the slide, the allele burden that was assessed by droplet digital PCR. After more or less 2-3 weeks of treatment, the patient experienced peripheral edema, especially localized in the lower limbs, ends, and periocular regions. That was accompanied by a weight gain of about 4 kilos. The remainder of the medical examination was completely negative, and especially there was any sign of heart failure. So how to proceed with the management of this effect? You can have some opportunities here: watchful wait, to withdraw the drug, to reduce the dosage of avapritinib, or to start low-dose diuretics. So 20 seconds to vote, please. Okay, this is interesting. So there are more or less 50% for dose reduction and 50% for low-dose diuretics. Actually, we decided for D, to start low-dose diuretics. As the event was quite mild, we had the opportunity to monitor the patient from a clinical point of view, and we decided to start to prescribe oral furosemide. And we observed a progressive amelioration of the effect until its resolution more or less around cycle 11 of treatment. And that gave us the opportunity to continue treatment with avapritinib at stable dosing. And we also were able to withdraw diuretic therapy without recurrence of the event later on. As regards hematological profile, we observed no major decreases in hemoglobin and platelet count. We observed a mild anemia that was fluctuating between 9 and 10 grams per deciliter, but without requiring transfusional support. The diarrhea resolved quite quickly, and the patient recovered to the baseline weight. And now the patient has been on continuous treatment for around 34 months. And that was my last slide, and I thank you for your attention.
I'd like to ask again to Professor Reiter, how much do you advise to search for NGS mutations in patients who are receiving target drugs, avapritinib or midostaurin?
We really do it in patients let me say, in which we also think that this may turn out to be a high-risk disease. So we are not doing it now in every patient, and we also do it in a restricted way, at least at the moment. I mean, it's still a lot about costs, although, you know, I do not like to talk about costs in diagnostics because we spend so much money on treatment, but this is always a very sensitive area. And sometimes we really restrict it, let me say, at diagnosis to the basic mutations, which we also found to be prognostically relevant, like SISF2, AS601, or RONX1. But was during treatment, and this is really the P53, TP53 mutations and RAS mutations, you know, not being available at diagnosis, but then turning up. I mean, these are really difficult and dangerous mutations. I mean, probably the second part of the question is, does it make any influence on treatment decisions? And I think, yes, it does. And I really think about allogeneic stem cell transplantation. Although, as I've already mentioned in this long answer to your other question, that allogeneic stem cell transplantation, I mean, it is in general a tricky decision, and it's even more difficult in patients with advanced systemic mastocytosis. I've already seen too many patients with rapid relapse. So, meaning that, for example, I am absolute somebody who would always recommend to use the tyrosine kinase inhibitors again after allogeneic stem cell transplantation for better control of potential relapse.
If I can make a last question, I noticed that there is the tendency from some labs to use NGS also at the time of diagnosis to search for KIT mutation. Do you think NGS is a good approach, or should we rely on real-time PCR methods, including digital PCR?
Is it to me again?
Yes, it's again for you, Andreas.
Okay. Well, I mean, as you saw, most of patients with advanced systemic mastocytosis have a higher allele burden of more than 5% in peripheral blood, which is probably in many of these assays the sensitivity limit. Some may have 3%. So I would definitely not recommend it for, let me say, general diagnosis or for general mutation testing in patients with advanced systemic mastocytosis, but this NGS testing, it may be good enough for the additional somatic mutations, but not for KIT D816V. And the second problem, just let me say that we have meanwhile seen really quite a proportion of patients with a much higher burden of additional somatic mutations, let me say 30–40%, and KIT D816V less than 5%. And these patients are also sometimes diagnosed as SM-AHN. But in these patients, it may really be prudent also to think about prior treatment of the AHN, because in these patients, the AHN part may be, let me say, something like 10 to 50 times as big as the mastocytosis compartment. So I think allele burden is really very important for diagnosis, for classification, and also for monitoring.
Thank you.
So it should be done.
I'm on mute. Can I just pick up on the NGS in terms of monitoring again? It's a real dilemma because, as you said, if you've got an AHN and they're responding to the TKI extremely well, but you want to monitor the AHN, you've picked up some other mutations. Do you wait for there to be morphological changes? Because that's what I've done in clinical practice. You start seeing subtle changes of the MDS or the CMML, because there's always, as you said, the push and pull of, do I do this, and will it make any difference if the mutations haven't changed? Will it change my decision making, or will it make it worse? But we're obviously saying that the AHN component needs to be monitored. So quite hard, isn't it? Do you have any other things apart from the fact that they've had bad mutations? Because we know these patients evolve mutations as they go along.
I mean, I think we see anemia, thrombocytopenia. It's difficult to say, is it toxicity or not? And then tryptase it's sometimes fluctuating. And I think the mutations could also be a good guide for doing another bone marrow biopsy. I mean, like all other patients in hematologic diseases, they do not like bone marrow biopsies. And I think in the clinical trial, we biopsied every 3 months, which is definitely far too much in the daily clinical routine. But for this disease, it may also be not enough to do it only every 2 years. And I think, I mean, it's not one marker. It's just this jigsaw of several markers. I mean, I also like, for example, alkaline phosphatase. I like tryptase. I like the blood count. I mean, it's always a whole picture. And what we also need really to discuss in far more detail in the future, this is also this type of heterogeneous response and heterogeneous progression. I mean, we here observe the same thing like on ruxolitinib in myelofibrosis. The patients are still doing very well on symptoms, and they have spleen enlargement, the KIT D816V allele burden rises. You think about, I would like to change, but now after avapritinib, at the moment, there's nothing really, let me say, commercially available or nothing approved. So we may go ahead and add something and not switch. So as I said, it's really the overall picture. The patient, his blood counts, tryptase level, KIT D816V allele burden, then maybe another bone marrow biopsy, and then to make the decision. Maybe also Olivier as the chair, I mean, he also has a lot of experience on patients with midostaurin avapritinib. What are your thoughts about that?
So what I said, it's we have seen that in mastocytosis, sometimes it's very difficult to see what is due to the EHA component or what is due to the mastocytosis at the diagnosis. And as we said nicely, we have to integrate all of the parameters. But then during the treatment of the patient, it depends also on the age of the patient, because in young patients who are fit for allo stem cell transplantation, with a donor, maybe we can go to 65 or 71 or 72, depending on the patient, to look at the NGS and the variation of different clones may help your decision, because, and sometimes between toxicity of the drugs, you have to reduce to in case of cytopenia, or progression of the HN component, in which you may add some 5-acetidine in case of MDS, and then discuss for stem cell transplantation, or sometimes you can remain at the same thing. So it depends on the patient and on the history, and we have to integrate all of these parameters, plus the fitness of the patient, plus the donor availability, and to make a good decision. It is what we do currently. So I think we have almost finished this very nice view on mastocytosis, and it was quite complex, and we have seen that for the last 10 years we make a lot of improvement in the diagnostic criteria, and now I think we have to use a lot of things, and molecular biology studies, including NGS, is quite important to have a good taking care of patients, mostly in advanced mastocytosis. And we have seen also that we use in the peripheral blood to make some diagnoses also, and as a prognosis tools. Also, I think it's also something that we have seen is very important, and we are lucky enough to have a good set of treatment, and definitely we have shown that the KIT mutation play a critical role in the physiopathology of the disease, and still we have a lot of things to understand and to improve in the future, but now we have a good tools in our hand to progress, and probably in the future will be also to discuss some combination. And I think probably the main topics of investigation will be how to treat the HAN component in this advanced mastocytosis, and probably also to move early in not aggressive mastocytosis, because we have seen that we improve also the symptoms of patients with KIT inhibition. So I will finish here because we are late, but I think we had a very good time today, and then thank you to all speakers and the organization, and also a Blueprint for put together all together and to have this nice meeting. Thank you very much.